Good morning. We're very fortunate this morning to have Dr. Stephen Gange as our speaker. He's professor in the Department of Epidemiology and deputy chair of the department. And he's going to talk to us about some methods development that he's done and how he's used it, emulating clinical trials using observational studies. So let me tell you a little bit about him. For those of you who don't know, he got his bachelor's degree in animal sciences and quantitative genetics at Cornell and went on to get his PhD in statistics at University of Wisconsin in Madison. He's interested in the epidemiology and statistics related to cohort studies and especially evaluation of therapies and biomarkers in observational studies. He's been working for many years with HIV/AIDS and heads the epidemiology biostatistics core for the NA Accord study. Here, I'll let him tell you more about his research because that's what we're all here for. Thank you.
Okay, thanks, Tim. All right. This is going to be loud. Okay. I don't want to wake everyone up so early. Okay, there we go. All right. So I want to talk about some work that we've been doing on this issue of using methods to emulate clinical trials. And I certainly thought this was the right audience to talk about that. But to get there, I want to talk a little bit about observational studies first. So I think we would all agree, hopefully would all agree, on the value of observational studies for investigating such things as the natural history of a disease, of a longitudinal cohort study where we can do pathogenesis studies, perhaps nested pathogenesis studies and nested case control studies within a cohort, as well as identifying those factors that we cannot manipulate and can't intervene on that influence disease progression. That may be things like host genetics, might be looking at the relationship of biomarkers over time, or might be looking at things like co-infections. Probably more controversial is the issue of use of observational studies for evaluating therapies and interventions. That's really going to be the focus of what I want to talk about today. And this encompasses kind of a lot of different features, such as looking at factors that affect the response to therapy, the occurrence of adverse events, and then actually measuring itself intended or beneficial effects of a therapy. So I like this quote. This was from a paper in the New England Journal a couple of years ago, which had is an editorial talking about some of these issues of use of observational studies for evaluating therapies. Had this quote: "When randomized controlled trials for a variety of reasons fail to provide data on overall mortality, should epidemiologic studies step into the breach?" Right? I love that term, step into the breach. And this issue of whether observational studies have a role for evaluating therapies evaluating overall therapies has been a theme of research over the last many years, 20 years, both in the general scientific literature as well as the field that I'm going to spend most of my time talking about today, which is HIV. And I think that this is a slide that I show talk about in some of our courses on what the role of observational studies is. And it goes back to the basic idea that clinical trials have a particular measure that they're looking at when evaluating therapies, and that's the term that we use. Efficacy is the term that we use for describing the type of measure that we get for clinical trials. Observational studies offer the ability to look at effectiveness, and effectiveness comes in two flavors. One flavor is what I'd call individual effectiveness, which is a measure that is trying to emulate what you do in a clinical trial and compare those individuals who are treated and untreated. An alternative thing that you can do in observational studies, one that I'm not going to talk about so much today, is what I'd call population effectiveness, which is looking at net effects or aggregate treatment effects that reflect not only measures of efficacy, but also how therapies are prescribed in the population, how people potentially become resistant, how they're actually used, and how that net effects or net use of therapy affects overall population level changes to treatment or to outcome distributions. So looking at, for example, over the course of time, I give this example a lot. Looking over the course of time, we know HIV therapies have rapidly, over the 30 years of the epidemic, came into their own back in the 1996, 1995 era. And we can look to see over the course of time what the net effect of those introduction of therapies has been in the rapid decline in mortality in the HIV population. That's a type of comparison that's very different from the type of comparisons that we do in clinical trials or in individual effectiveness studies. So let me just highlight these issues. We know and I think we still teach that clinical trials are there to measure efficacy, and efficacy can pull out your dictionary of epidemiology and define it as the extent to which a specific intervention produces a beneficial result under ideal conditions. Right? And these ideal conditions may be including selected compliant populations, expert physicians who are involved with the study, who are doing close monitoring of individuals who are participating in the study, limited time frames, and a lot of times intent to treat analyses. And this contrasts with the idea of individual effectiveness. Effectiveness, again, pulling out your dictionary of epidemiology, can be defined as the extent to which specific interventions, when deployed in the field, does what is intended to do for a defined population. Right? So moving away from clinical trials, moving towards the deployment of therapies in real life, individual effectiveness investigations typically assess the impact of interventions not when they're randomized, but they try to emulate the type of comparisons that you would make similar to a clinical trial, i.e. you comparing those that are treated and not treated. And we're evaluating typically effects of a treatment, typically in different populations than a typical clinical trial population or different time frames. Just to give an example of that, this comes from a paper that we published a couple of years ago that was illustrating the importance of effectiveness studies. And what this is a plot in which we took, many of you have heard about the WISE study, the Women's Interagency HIV Study, which is a study of HIV-infected women that we have here in the United States. It's been going on since 1993. It's an observational clinical cohort study. It reflects the epidemiology of HIV here in this country. Largely inner-city women who have a racial makeup, who have a lot of other things going on in their lives that reflects, again, where HIV is in this country. So what we did was to go to the literature and look to see what were the criteria that the clinical trials published and in terms of their eligibility criteria, and then applied it to our cohort. And we wanted to see, of the women in our study, how many of them would be eligible for individual clinical trials, right? Or in this case, this is a percentage of individuals who are excluded, who would not be eligible from individual clinical trials. And you see that the percentages here are pretty striking, right? We have a cohort of women who reflect HIV in this country, yet anywhere from about 30% to almost 70% of the women in our cohort study would be excluded from these HIV clinical trials. And the other, since this is a methodologic audience, I'll point out another thing that we did was to not only go and look to see what were the eligibility criteria in the publication, but we actually went back and got the protocol itself and looked to see what were the criteria that were in the actual study protocol, and found this difference in many clinical trials, that what they published in terms of what the eligibility criteria were often quite different from what was actually in the protocol, right? And in some cases, it would look like, so each of these bars is broken up by the percentage of women who would be thrown out by just looking at what was published versus women who would be actually thrown out by what was in the protocol. Illustrating, the importance of, when publishing the results of clinical trials, ensuring that what you say when you write it up is actually what you do in practice in the protocol. But the main point of this was just to illustrate, the importance of looking at effectiveness, the importance of looking at the effect of therapies in populations when maybe upwards of over 50% or 70% would not be eligible for a clinical trial. The other thing to mention is how short clinical trials are. So this came from some flyer that I saw a couple of years ago that was promoting the use of biomarkers, and it was touting the fact that in HIV the use of these CD4 and viral load biomarkers enabled the development and approval of drugs in about 3.5 years. Right? We're talking about a disease where people have to be on therapy lifelong. And here, the whole approval process has been narrowed down to 3 years. So illustrating that clinical trials, largely clinical trials are not oftentimes looking at the right patient populations, nor are they following people for a long period of time. And the question is, does it matter? Does it matter that we study in observational studies how therapies work relative to what clinical trials actually produce? And this is just 2 slides illustrating some results from, in terms of CD4 responses for a major clinical trial that was one of the pivotal trials for one of the main backbones for antiretroviral therapy, as well as data from our own studies looking at those who are actually treated and how their CD4 cell counts come up. And if you look at both a particular clinical trial or a set, there's some meta-analyses out there of clinical trials, the results that you see, the changes that you see are often very optimistic, right? And the changes are typically very strong, showing striking in clinical trial settings, striking responses that, when we look to see it at a population level in this effectiveness framework, as therapies are being deployed, we don't always see those kind of responses. So the idea here is that evaluation of therapies in observational studies is supplementing the results of clinical trials. All right. So if I can convince you that there is utility in doing this, then we have to start thinking about the challenges of looking at interventions in non-randomized settings. And it's certainly, these a lot of things I'm going to talk about, not necessarily unique to interventions, but they specifically come up because we have clinical trials as an alternative design. So we know this, right? We know randomization is a tool to ensure, on average, treated and untreated groups are comparable with respect to known and measured confounders, as well as with respect to unknown and unmeasured confounders. So what else can we do to ensure better inferences? What can we learn from clinical trials, not only in terms of thinking about randomization, but how they're set up for doing our observational studies the right way? So the first thing we need to do is acknowledge it, right? And ensure that when we go out and say we're going to evaluate therapies in observational settings, that we acknowledge that there are challenges and keep that framework in mind. This is not me, by the way. This is a picture from the internet. All right. So one thing that's important, I think is important, is this idea of studying the factors that are related to the treatment decisions. Right? Clinical trial, you don't have to do this because the treatment is randomized and you have the randomization mechanism there, at least at baseline. Whether people actually continue and take therapy and adhere to it is another consideration. But in observational studies, in non-randomized situations, we need to understand better the factors that are actually related to treatment decisions. And it's multifactorial. We have to understand those decisions, why someone initiates therapy, what they initiated with, whether they might switch therapy, what they switched to, and why they might have downshifted or discontinued. And this is why a lot of in HIV, we've been doing a lot of this, trying to understand the factors that are associated with use of therapy. I'm not going to go over all of these, but I just want to mention how important it is to understand those factors. I will point to, actually, this isn't work by us. This is work by Debbie Lawler and others in this great paper that was published a couple of years ago. Those, the doctoral students who are here will know this. We talked about it a couple of weeks ago. This was a study looking at this difference between observational and interventional trials, and in particular, looking at the results and trying to understand why the observational studies, when studying the effect of, in this case it was vitamin C or vitamin E, I think I focused here all on vitamin C, the observational studies were so strong, right? They came out and said, look how good the additional intake of vitamin C is for in this case, cardiovascular disease outcomes. And the clinical trials were done, and the clinical trials came out, and they showed no effect at all. Right? So this was one of the studies that was trying to pick up the pieces and understand why there was this discrepancy. And I show this table a lot because I think it's very important to this idea of understanding why people are on the things they're on. So what they did was they broke out individuals by actual vitamin C, so this is their exposure along the top, and identified people in different quartiles of vitamin C. And then they looked at a bunch of different factors. And in particular, not only factors and behavioral lifestyles at the time, they at a contemporaneous time, but they actually looked backwards in time as well to really try to describe who's taking these therapies. And so they looked at things that occurred in these individuals' childhood, whether social class, whether they had hot water, whether they had a bathroom in the house, whether they had car access. They looked at adult social class, whether they're pensioners, percentage on housing, as well as a bunch of behavioral and lifestyle factors. And as you see here, as reflected by the summary odds ratio over here and the p-values, every one of them is statistically significant. Right? This is saying that all of these factors, all of these lifestyle factors, historical factors between these groups are all different, and illustrating how hard it is in observational studies to tease apart all the confounding factors. Right? These people are different. They're not only different with respect to current behavioral and lifestyle factors, but they're different way back in time, right? From probably the time of birth. And some of these, some of the things are stronger than others, but this illustrates, again, the point of understanding who's actually exposed and who's actually taking therapy. So that's what we've tried to do in HIV studies. I think this illustrates a lot of important work that we still have yet to do for understanding better factors that are related to use of initiation of therapies as well as their continued use. Okay, so another thing that I try to promulgate is this idea of thinking like a clinical trial. Not in terms of necessarily just in terms of randomization, but how a clinical trial is actually put together. And this relates to the idea that when we do a clinical trial, and we're going to simplify it to a treatment versus placebo, we don't take people who've just been on the treatment for however many years. Right? We have a point of randomization, and you either initiate and start taking the therapy, or you get assigned to another arm. And methodologically, this brings up the idea that there aren't people who are on prevalent treatments. Right? We pay attention to the point of that they initiate, and the important idea of immortal person time, of ensuring that there isn't, by the way that we've set up our analysis, there isn't periods of time when we're including them at risk for the outcome when they wouldn't have been really at risk for the outcome. And clinical trials don't have these problems, right? If you set up things the right way, you don't have these problems, but they do plague observational studies. So I want to, again, I'll use a non-HIV example here, bring up the differences that occurred between observational and clinical trials with postmenopausal hormone replacement therapy. Right? And hopefully most of you know this story. Hopefully most of our doctoral students remember it again from a couple of weeks ago. The important part of lesson from this trial was exactly this issue, that the observational studies or the clinical trials are balancing people who are either initiating or not initiating therapy at a particular point in time. And if they have prior history, that typically tends to be balanced between the two treatment groups. In an observational study, you have to make a decision and say, all right, this person is taking the therapy and this person isn't. And that's reflected here in the bottom part of this table. It shows that individuals broken out in the observational study looking at the effect of hormone replacement therapy, whether they're never users or current users. And so, by definition, in an observational study, we look and we see, all right, who's currently using hormone replacement therapy, and we compare them to people who aren't using it. They may have a little bit of history in the past of its use, but they're currently not using it. Well, if we then look at the characteristics of those who are using a therapy right now, it's not as though they all just initiated, right? They all just didn't start. The individuals who were reported in the observational study had been on therapy for a long period of time. Right? And this illustrates the duration of therapy that they were on. And you see this huge imbalance. They have most of the people who are on therapy have been on therapy for a long period of time. And if there are risks that are constant over time, this isn't a problem. But if there are risks associated with the therapy, immediate risks upon initiation, then we're going to run into trouble. And with hormone replacement therapy, that's exactly where the risks are. The risks for, this is 3 different outcomes, coronary heart disease, stroke, and VTEs. You see let me focus on these 2 since the effects are strongest. The risks of the occurrence of these adverse events are highest shortly after initiation, and then they tend to go down. Right? VTEs here, the risk is 3-fold higher for those using therapy or initiating therapy in the first 2 years as compared to later time points. So if we have a comparison of individuals who are in clinical trials, we have this balance. We can look at this effect. In observational studies, if we ignore the fact that people have been on therapy for a long period of time, we end up with data that are weighted towards greater duration. which makes it look like the therapy isn't so bad. And in fact, it may look like the therapy is actually good for you. Whereas the risks are occurring early, we didn't have any data in that, there weren't any data in that strata, right? The individuals who were on therapy were primarily weighted this way. So the type of comparisons that we do with those people who aren't using therapy and those who are using therapy is a mismatch. And this is a really nice paper, again, from a methodologic standpoint of illustrating the importance of thinking like a clinical trial. Thinking about when we do comparisons of those on and off therapy, we just don't take people who are prevalent therapy. We take people who are actually initiating it and looking at their risk over the course of time. Okay. So the other thing I want to mention is this idea of using analytical methods that address the complexities of observational studies. And many of you know there have been great advances over the last decade. Certainly in HIV, Division of AIDS has been very supportive of methodologic development, in particular the rise of causal inference tools, which are somewhat, the name causal inference implies you're getting at greater cause. I don't necessarily prescribe to that. I don't think it's any more causal than other statistical tools, but they do provide better ways of handling some of the complex issues, particularly that come up with non-randomized therapy. And you've heard about propensity scores and inverse probability weights. I want to talk about a particular use of these approaches for a problem that we had, which was looking at the impact of whether I initiate a therapy early or whether I delay. Right? So we know in HIV these therapies have been around for a long period of time, going back to 1996, with the introduction of protease inhibitors that constitutes these cocktail antiretroviral therapy regimens. So we have drugs that work and reduce virus and reduce endpoints. The question, that has been ongoing since that introduction of therapy is, when do you initiate therapy? When do you actually start these therapies? Should I start them immediately, or is there a benefit because of the risks of toxicities, the risks of developing resistance, the loss of therapeutic options? Is it better to potentially, since HIV is more of a long-term disease, can I wait a little bit, wait until I really have a much higher risk, and then initiate therapy? So there are potential risks with initiating early. There are potential benefits of preventing disease progression, as well as preventing other degradation of the immune system. So I'm going to talk about some work that we've done, that ended up in New England Journal using some relatively complex causal inference models. I'm not going to go through all the details of that. What I want to highlight are all the choices that we had to make when doing this type of analysis, of trying to evaluate this question in an observational setting. And while the causal inference tools were an important part of this, and I'll comment on some of those issues, there were a lot of other choices that we had to make before getting to that point.
What's artificial censoring?
I'll talk about that. Yeah. All right, so I'm not going to talk about every one of those components. I'll talk about the key ones. So one of them just has to do with this idea of framing the question. Right? And our approach from the beginning was really to try to mimic a clinical trial, partly because we know that Division of AIDS has been interested in funding a clinical trial for this question. And so we approached it like a clinical trial. What do you have? You have an eligibility criteria. Who would be eligible for this trial? Well, there would be people whose CD4 cell counts, which are one of the major determinants of disease progression, biomarker for disease progression, is in a particular range. And in this case, I'll talk about between 350 and 500. And these people have to be coming in, they have to have no history of therapy and no history of clinical AIDS. what we were trying to mimic was a trial that was doing randomization where you would be randomized to one of two groups. You would either initiate therapy immediately, or you would be assigned to a deferral group, and the deferral group would wait until your CD4 progressed to some level, and then you would initiate therapy. So pictorially, we have this. Right? We have individuals who are coming in whose CD4 cell counts are between some sort of level. They would be randomized to either initiate it immediately or defer. The deferral would wait until there's some sort of transit, their CD4s decline, and then they would initiate therapy. And then all individuals would be followed. Our outcome here was all-cause mortality. So that's what we were trying to mimic. Now we didn't do a clinical trial. We used observational data to do this. The choice of what data set that we actually went to pursue, as well as the methods that we used for putting all of these data together was pretty extensive. This is falling under a large study that we have. I'll highlight it in 1 second. But these are some of the choices that we had to make in terms of what cohorts are going to participate in this, what time frame, what are the data collection methods, completeness issues, harmonization issues, how are outcomes ascertained, all the same kind of questions that you would ask in a clinical trial and set up in a protocol. So we did this using a collaboration of cohort studies under this umbrella of NA Accord, which stands for the North American AIDS Cohort Collaboration on Research and Design. This is a collaborative cohort study of over 22 cohorts in the US and Canada, constituting over 100 sites and 110,000 HIV-infected individuals. So for a lot of reasons, it was the perfect data set to address this question. We had good representation. We have a large number of people. We're using data from cohorts that are ascertaining mortality and have good collection of exposure information, biomarker data, and outcomes. So we have all the components. Then we had to start to put it together. One of the first things that we had to deal with is the fact that, unlike a trial, we don't have a time of randomization. Right? We have people who are being followed in time, people initiating in different in different windows. So we had to define a way that would illustrate or really define the two treatment groups that we were interested in. Right? So we're interested in mimicking a trial where people initiate immediately or those that defer. So in order to do that, the idea of immediate had to be thought about, because the patients won't necessarily initiate immediately upon eligibility. There are aspects of even in nowadays with people getting on therapy, getting ensured that their insurance is set up, getting plugged into the networks, etc. So we had to define windows of time that would say, all right, if you initiate within this window of time, we're considering you as an immediate group. And if you don't initiate in this time frame, then you're in the deferral group. Right? So pictorially, we come back to this picture, and so we're defining a window of time. So if you don't initiate in this particular window, we call you deferral. And what we expect to see is that if you defer, you transit, you have to initiate within a particular window after you transit. So one complication, again, the complication that comes up because we're not doing a trial is the fact that we have to use these windows and things can happen. People can do things that are not according to the protocol, right? There can be people who, or people that we have to think about, who might, in this particular window, are going along, they don't initiate, but then they fall below 350 in this window and then initiate hard. How do we define those people? Are those people in the immediate group, or are they in the deferral group? They're in the immediate group in terms of time because they initiated in this time frame of the window. But they're also in the deferral group because they initiated after they had a CD4 that went below 350. So you can make arguments one way or another about where these people should fall. Fortunately, the number is relatively small, so we didn't have to worry about it. but it is part of the sensitivity analyses we did. The other thing that can happen, people can die in this interval. If it's not a interval of 1 day, people can die. Again, the numbers are going to be small, but we need to think about how to handle those people in the analysis. And lastly, we also have to worry about those people that are going to initiate late. And this comes up actually in 2 frames. So these would be, in a clinical trial, these would be people who are violating the protocol. These would be people who come along, don't initiate in this window, so they would be called the deferral group, don't transit, don't have CD4s that fall below this level, but then initiate out here. Right? Those would be people, who would be in a clinical trial, possible crossovers. Right? At the point of randomization, they weren't allocated to this particular group, but then crossed over to initiate therapy. The other group we have to worry about are those people who don't follow the other part of the protocol, who defer heart, have their CD4s decline. What we expect them to do is initiate heart immediately, but they don't. And they don't initiate in this window. So again, these are people who are would be randomized in a clinical trial, randomized to initiate in this period of time, but even this would be a matter of non-compliance with this therapy. So both of these are deviations from the protocol that we have to deal with. So the way that we deal with them, this says just what I pointed out there. What can we do with them? Well, one thing that we could do with them is ignore them, right, and pretend we're doing an intention to treat analysis of just saying that, well, we know that there are going to be individuals, even in the clinical trial, who deviate from the protocol. Let's just treat them as they were assigned. The problem is, that's not a good approach. If there's a large percentage, even in the clinical trial, that aren't adhering to the protocol, we know that that's a bad thing and that we need to do something about it. So one of the things that you can do, either in a clinical trial setting or in a observational settings, is censoring. So this is the issue of artificial censoring. So you follow people up until the point that they deviate from the protocol. And then if they start to deviate, you censor them at that point. Now, the problem that comes up is this may induce selection bias, right? We know that this kind of censoring, the people who are deviating might be the people who are, let me go back to here, the people who are initiating therapy at this high level may be initiating for a reason, right? Maybe they're sicker. Maybe their doctor said, all right, because you have hepatitis, because you have, other conditions that we aren't capturing by CD4, you should get on therapy. On the contrast, the people who aren't initiating it might be healthier, right? Those people who are maybe I came down, this is still a relatively high level in HIV of 350. If they, reach 349 and then didn't initiate, maybe they didn't want to initiate. Maybe the doctor said, well, I really think that your viral load levels are low. You're able to continue with therapy. So there are potential reasons for why people aren't initiating therapy or are initiating therapy. And we have the potential for selection bias if we do this censoring. So one way that we can get around this is using weights. This idea of deriving weights and using these to help us account for this selection bias and upweighting certain individuals, downweighting other individuals to try to make it so that these potential selection factors, provided we're able to capture some of them, are able to eliminate any selection biases. So that's what we did. We developed these models for artificial censoring. So we developed models so that we are predicting who is being artificially censored based on other data we have in the database. We use these models to develop weights. We use these weights in the analysis. And there's a whole bunch of choices that go into how to set this part of it up as well, including the person time that we actually use for identifying these weights, the variables that we include, how we stabilize, truncate, or assess these weights as well. And just to give you an illustration, this is a plot of some of these weights. And what it shows is these weights are standardized so that I won't go into all the details of this, but if there were nothing going on, we weren't able to predict anything in those using these models. All of these weights would be exactly equal to 1. And we've split it out by those that didn't have or did have censoring versus those who didn't. And you see the overall distribution here has a median of about 1, and while there's a lot of scatter here, most of the distribution is actually tightly bound around 1. But we have these weights that get pretty big, right? And what does this say? This says that we're upweighting, we're taking the data from one person, and we're multiplying it 100 times, right? And we're pretending like there are 100 people. Well, that may not be the right thing to do, right? That's going to potentially heavily influence our ultimate results. While most of the weights are here, this idea of, through a model, trying to use these weights to come up with comparability between these groups can end up with weights that are very big. So there's things that we can do, this idea of truncating weights, looking at the distribution, trying to ensure these weights are not upweighting or downweighting people by quite a bit. So those just illustrate some of the choices that we have to make. Then, once we have all of those components, right, we have the population, we have the framework, we have this issue of censoring people, we have these weights for fixing up censoring, then we actually have to get to what analysis we're going to do, and all the usual things that go into an analysis. What form of the model we're going to choose, whether we're going to do stratification or adjustment with respect to a number of variables. If we do adjustment, put in things, baseline confounders such as age, sex, initial CD4, and we looked at a number of other things. How we actually incorporate those variables, whether we put them in as categories, categorical variables, linear variables, splines, etc. It's all the model building stuff that we all have to face whenever we do a statistical model. So despite all of those things, right, and the many months it took, to make these choices, to set up the data, to set up the analysis, ultimately, we came up with results. And these are the results that we published, that we're looking at two particular time points, or CD4 windows. So look at those people who are coming in with a CD4 between 350 and 500. What's the impact of initiating immediately versus deferring? And also among those people coming in greater than 500. What's the risk of deferral as compared to initiating immediately? And that's reflected here. These are two models, with and without viral load as one of the predictors. The important variable is here, which illustrates the relative risk of deferral. So this is saying that deferring is risky. Right? There's elevated risk of mortality for those people who are deferring as compared to those people who are initiating immediately. And that's controlling for these factors. It's controlling for the selection bias factors that I talked about before. And, we did a whole host of sensitivity analyses to go and challenge this model. For the most part, it was very stable. One of the factors that probably influenced this result the most was the choice of weights and how we actually dealt with the weights. This idea that we could potentially overweight people by including weights that were very, very big. So we modified that. In no case did we ever see effects that went, certainly in the opposite direction. All it did was attenuate some of the effect. So this was for the 350 analysis. This is what we reported. And if we truncate the weights more and more, so that even if we go to a model that doesn't have any weights, we see an effect that shows relative risk of deferral as compared to initiating immediately. So it's still there, and we see this gradient as we allow the weights to become bigger and bigger. And then there's also, again, other sensitivity analyses, something that I think we don't emphasize enough in our analyses, of looking at things like leaving out cohorts one by one. So we left them out individually. We had some very large cohorts that we were concerned about. We also looked at type of cohort. I won't go into this, but cohorts like MAX or WISE or ALIVE, which are interval cohorts that are outside of clinical care as compared to our clinical cohorts. We looked at different ways of modeling the exposure variables and the other confounding variables, and then did a whole host of subgroup analyses. And then one other thing that we did were some simulations looking at the influence of unmeasured confounding, right? Because the biggest concern for this analysis was that there was some difference that we weren't measuring between those who were treated immediately versus deferred. And this was basically a simulation where we assumed that there was some unmeasured confounder out there that had some sort of association with the exposure and some sort of association with the outcome. And then we looked to see, the assumption under the basic model is that it's not out there. Well, if we crank this up, what you end up with is an attenuation of your effect, depending on the strength of the association with the outcome and the exposure. So the more we crank that up, the more attenuation we would get. So our question was, how much would this association have to be to make the effect really diminish? And this illustrates that the factors that we have to be looking at would have to have a relative risk of let's say 4 with the exposure, or an odds ratio of 4. So it would have to be strongly associated with the exposure, strongly associated with the outcome, so a 4-fold increased risk of death, to bring this magnitude down from 1.6 down to 1.3. And it also relates to the prevalence of this unmeasured covariate, and I won't go into all the details of this, but I think this kind of sensitivity analysis, again, is something we don't emphasize enough when we do observational studies, and how relatively easy it was to actually do this. Right? Actually simulate, using a data set, pretend that you have another variable in your data set, plug it in and run it, and simulate it under different settings. It was certainly very helpful to convince people about the robustness of our result, because we would expect, clinically, we would know factors that showed a 4-fold increased risk of death, or 4-fold increased risk of being use of therapy immediately. All right, and just a kind of the coda to the story was that our data, as well as other data, as well as pathogenesis data that's been coming out over the last couple of years, has really illustrated that initiating therapy earlier is beneficial. And the guidelines for HIV have been evolving more towards earlier therapy. I think some of our data has helped, as well as other data from other individuals, as well as better understanding of the disease. So just to conclude, hopefully I've convinced you that observational studies for evaluating interventions should be viewed as partners to clinical trials. There's a lot of choices that need to be made. I would argue that the trialists, a lot of you in the audience, should not only promote randomization, but also this idea of setting things up as a clinical trial, thinking about protocols, thinking about how you set up data, things that come very naturally to a trialist, for clarifying a protocol, for ensuring that you don't have prevalent therapy and immortal person time. This is the kind of thing that should be part of the dialogue with from trialists to push the field in a better direction. And I think observational studies and people working on this have improved their methods. We're not perfect yet, but I think by this framework of trying to mimic approaches in clinical trials, we're gaining in terms of the type of inferences that we're making. And certainly causal inference models are one component of that, but as I've illustrated, there are a whole host of other questions that and things that we have to deal with. And it's important not to forget those. And with that, I'm going to stop and open it up for questions.